Thanks, Susanna, for joining us here in Bad Hofgastein. We just had an excellent panel where you were joined by some of the cardiovascular experts in the field. You yourself being an acute cardiologist, as well as the chair of the Advocacy Committee for European Society of Cardiology. So we also had Commissioner Varhelyi give some insights into the cardiovascular plan that we expect by December. And we heard a lot, one of the big items in this plan will be about know your numbers, cardiovascular health check. So it would be good to, if you can share with us a bit more, what is this, what does it mean, and what is the potential of having people check their numbers?
So, thanks for the opportunity to have a bit more of a chat about what we discussed in the session. So I think it was a great session, and we heard from a number of experts. And the bit that I focused on, because we were all asked to say, what were the key bits we'd like to have in there, and why. So the concept of knowing your numbers, I think for me, it's really about giving agency and empowering individuals to start with, that it should become a norm that you know what your cholesterol is, you know what your blood pressure is, you know what your blood sugar is, and you know what your BMI is. Because then if you know what they are, then you can act on them, or at least you can have agency to discuss with whoever your primary care clinician is, or your practice nurse educator. But if you don't know what your numbers are, then you can't do anything about it. And we know there are a lot of people walking around that don't know. And of course, these all convey extra cardiovascular risk, so that's heart attack, stroke, dementia, as we heard, and also for cardiometabolic risk. So giving citizens that sort of, it becomes normal that you should know from the age of 18. Do you know what your blood pressure is? At what stage you're going to start measuring people's cholesterol? If you've got extra risk factors, maybe a little bit earlier, and then preventing people getting sick, so they stay hopefully healthier for longer. And the only thing I would add, which I put in at the end of my discussion, is that too often when we talk about cardiovascular risk, we become a bit blamey, and we say we play the blame game with people. Say, oh well, they smoke too much, or they drink too much, or they don't exercise enough. But we don't tend to do that with other diseases, but we do with cardiovascular, and the risk factors are pretty common. So in addition to individual risks, I would like us to look at system risks a little bit. So this would be, it's not a citizen's fault, or indeed necessarily their free choice, that they have easy accessibility or availability of very sugary drinks, ultra-processed food, that they're being maybe targeted by tobacco and tobacco products. That actually comes down to policy rather than individual choice. So 100%. I'd like to see individual risks addressed, but also system risks addressed.
And it links very nice to the theme of this year, which is all about solidarity, leaving no one behind and not putting it just on the individual.
Absolutely.
Yeah. And then another area which I think is interesting, and we talk a lot about AI and the potential of AI, but it also comes with some caution and risk. So in terms of cardiovascular health and the plan, what would you like to see in there, or what do you see some of the opportunities and risks? Thinking about data, there was one question on the data that forming AI needs to be good. So how can we ensure that or help that?
So of course, there's artificial intelligence is here. It's not something for the future, and it can be regarded as a bit of a black box. Who knows what goes in, who knows what comes out. What we know is that it will learn what we tell it. So if you ask AI to look at trials, clinical trials, and base recommendations or whatever it learns from it, it'll only learn from the trials that have been done. So we know, for example, women have been excluded from a lot of clinical trials. Our ethnic minority groups have not been well represented. So we need to bear that in mind when we look at whatever comes out from AI and the AI algorithms that are developed. That said, the opportunity or ability of AI, if used wisely, to transform how we use the data, so say you know your numbers, or if you look at population numbers or system level numbers, it's extraordinary. So we've used AI within cardiovascular medicine for a long time, so ECG interpretation, but that's now moving to a different level. Pacemaker programming, wearable technology, inable as well as wearable technology is all there. In terms of heart failure, for example, predicting deterioration, predicting decline, the potential numbers from that and the bigger use of AI is extraordinary. So I think for me, it's the additional insight that one could get on an individual level to recognise risk potentially earlier or manage the interventions that you need. So much more personalisation of the medicine that you're needing to take or whatever it is that you need to do. Also to help the clinician. So which patients are the ones I really need to focus on and maybe predicting decline earlier. And then at population level, where are the areas that there's really a problem? Where do we need to target? And then potentially real time knowing what the impact of interventions are. So having said all of that, yes, we need to be careful. We need to be thinking about the ethical use of artificial intelligence. We need to have a regulatory framework that makes sure it's safe. And I think the EU is perfectly positioned to do that extremely well. And we need to make sure it doesn't widen equity access. We need to make sure that equitable access is absolutely embedded. And of course, it has to be transparent to the citizens, to the clinicians, and of course, at a healthcare system level. Yeah,
thank you. Well said. So we have a lot of hope and we're really eager to see what is really printed in the plan when it gets published in December. And maybe a last message you shared very eloquently in the last speaking points on the budget need and the comparison with cancer plan, that there's no competition. But
yes, exactly. So, there is no competition. A lot of the risk factors are the same, and, we're all people. We're all at risk of cardiovascular disease. We're all at risk of cancer. I would like to see that the budget ask is equally equitable between cancer and cardiovascular medicine. That's what I'd like to see.
Yes, me too. Thank you, Susanna.
It's my absolute pleasure.
Thank you.
Thanks.